And then I want to introduce Dr. Lance Plyler from Samaritan's Purse. Or Samaritan's Purse, I should say, is one of our gold sponsors, so we are deeply, deeply grateful for that. And he's going to come up and just say a few words to you about Samaritan's Purse and what they do and whatever is on his heart. But Dr. Plyler is medical director of the Disaster Response Unit at Samaritan's Purse, and he's practiced medicine domestically and internationally for at least 15 years. At Samaritan's Purse, Dr. Plyler leads strategy efforts to enhance capacity for medical interventions and disaster preparedness. Most notably, recently, he helped lead the Ebola response in Liberia and was honored corporately along with a number of other really courageous individuals as Ebola fighters. I think that's what they called you, as Time Magazine's 2014 Person of the Year. And last but not least, maybe most importantly, he's a new board member for CCIH. So Lance, come on up and the podium is yours.
Well, thank you so much, Garrett. I am very delighted to be here on behalf of Samaritan's Purse. Actually, I've known about CCIH for a number of years, and I must confess this is my first year being here present, but I plan to attend for many years to come. I'm here with two of my colleagues. I just quickly, I'm not even sure if I see them, but Karen Massey is our Program Development Officer for West Africa. And Janet Ossel is our Senior WASH Advisor for Samaritan's Purse, so I'm delighted to have my friends and colleagues with me in the crowd. I want to say that Samaritan's Purse is indeed a tremendous advocate of what Christian Connections and International Health stands for. In particular, their mission, which is to address issues of global health and wholeness from a Christian perspective. We very much share that value. And so I'd like to say that we're in alliance with CCIH and you, its organizations that it works so closely with. Samaritan's Purse was founded in 1970, not by the Reverend Franklin Graham, but actually by Bob Pierce, who coincidentally started World Vision, as many of you all know. Samaritan's Purse, let me just give you a little bit about it. It was founded on the principles of, if you go in the Bible, Luke chapter 10. Of course, we're all familiar with the Good Samaritan. And just real briefly, the Good Samaritan, there was one traveler amongst the three that reached out to the gentleman that was attacked by the thieves. And he reached out to him and he provided for him. He bandaged his wounds. He cared for him. He put him on his donkey, and then he transported him to the inn, and he gave additional money for him. And Jesus mandated for us to go and do likewise. Go and do likewise. And so that's what I think really all of us corporately are trying to do. We're trying to embrace that principle. And as I said, that's what Samaritan's Purse was founded on. It too was started off with very modest beginnings. Like Dr. Lane described, Liberty College or Liberty University in the mountains of Virginia. Samaritan's Purse is in a little town called Boone, North Carolina, the rural mountains of western North Carolina, and was really just a grassroots NGO. But under the leadership of Franklin Graham, it really has risen to an international player, a multi-sectorial relief organization that is again trying to go and do likewise. The one thing that I can really say that I'm proud about working at Samaritan's Purse is that it still very much emphasizes the gospel and again the message of the Good Samaritan without compromise. I think we're seeing a lot of compromise today, but we really adhere to the gospel, and so I'm very much proud of that fact. And I think CCIH is in accord. We see eye to eye with those principles, as do many other organizations, all the other organizations here. I want to close by just reading some scripture. It's really prophecy. If you go to Mark 13:7 through 8, It says, "And when you hear of wars and rumors of wars, do not be alarmed. This must take place, but the end is not yet. For nation will rise against nation, and kingdom against kingdom. There will be earthquakes in various places." I know that personally. "There will be famines, and these are but the beginning of birth pains." So I think it's very clear from a biblical perspective that our work is before us. There's much work to be done. And I think more than ever, it is imperative that we come together collaboratively to build up the body of Christ. And that's what I see Christian Connections and International Health doing. And so Samaritan's Purse is very honored to be here and to partner with CCIH and all of you. Thank you.
Well, good afternoon, ladies and gentlemen. It doesn't sound like you had lunch. Let's try again. Good afternoon, ladies and gentlemen. Very good. It's my pleasure to welcome you again. I know you've been welcomed, but we appreciate you being here to participate in CCIH's 2015 conference. I began out here a long, long time ago, about 7 years ago as a student, and with very good nature, CCIH has turned me into a decent community health worker. So it's a pleasure for me to be facilitating our plenary this evening. I just want to say that I believe that it's because of the work that you do, one, in recognizing the needs and responding to the needs of God's very poor, that we're able to gather today to celebrate what you do, but also to really challenge, inspire, and encourage each other to learn a little bit more and go back and do even better for the kingdom of God. When we were little kids, we used to pray that God will turn us into people that would do valiant things for Christ. So it's always nice when we have conferences like this where people can encourage and inspire each other to learn and to do more and to actually grow in strength, from strength, to increase your influence for God's kingdom wherever it is that you serve. I spent 5 weeks, the last 5 weeks in Uganda working with a malnutrition program. And as we're interviewing about 120 women, going to their kitchens and doing food inventory of what they had, I was struck at how much people are struggling with very, very, very basic needs, which helped me as I came back on the plane contextualize our conference theme even more as I traveled back. And I think the question that a lot of you might be having, which is what I have, because I know in your work day to day, you face poverty in what you do. And we have had a lot of information, and at the end of the day, usually my question is, how do I use a lot of the new information I have heard to integrate as much as I have had in my work? I am privileged to introduce our plenary for today, as I believe they will probably help us walk through some other practical ways in applying what we have learned to strengthen our programs to respond to the need of God's poor. So they will take time to introduce themselves because they will do a better job than I will. And then hopefully we'll have questions for them and engage in a good discussion this afternoon. Again, welcome and thank you for being here.
Thank you, Dr. Pam. It's great to call you Dr. Pam after all these great years working together here at the CCIH conferences. Good afternoon. My name's Adrian Kerrigan. I'm the Senior Vice President for Partnerships at the Catholic Medical Mission Board, CMMB. And I'm sure many of you know CMMB from our work together in the developing world. And just for those of you who do not, we're a 103-year-old organization headquartered in New York City, with offices in 5 countries, in Haiti, in Peru, in Kenya, Zambia, and South Sudan. Our work traditionally has been in providing healthcare volunteers and medicines to religious congregations worldwide to support their work. And that evolved over the first 80 years in primarily being a Catholic charity and providing those free to the poor and vulnerable who needed them worldwide, and we've worked in over 110 countries during that time. And then during the HIV/AIDS crisis of the late 90s and early 2000s, we were identified as one of the key faith-based leaders in providing support for the HIV/AIDS epidemic, and worked with PEPFAR in building out programs in those 5 countries particularly. So we have a great network around the world, and it's great to see so many of you who we've worked with over our history. And my role now as Senior Vice President for Partnerships is to say, let's work even more collaboratively to really address these healthcare needs in strengthening health systems and providing a way in which we can work to alleviate poverty, which is the fundamental reason why we're having so many health challenges today. So that's my goal. And so we've come up with a platform after a deep strategic review. New CEO joining CMMB about 3 years ago. Many of you know him, Bruce Wilkinson, who used to head up World Vision Africa programs, is now our president and CEO. And Bruce very strategically came in and said, let's take a look at the things that we've been doing worldwide, what's been working, and more importantly, what hasn't been working, and let's really direct our new strategy to be more strategic. So we kind of narrowed our focus now into more of a maternal and child health paradigm. And we're really going to be focused on the 5 countries where we have offices and where we can really do the best in building off the infrastructure we've built for HIV/AIDS, and now really address maternal and child health issues, and work to really increase people's access and the ability to afford health care within their contexts. So we've been doing a lot of deep assessments with the communities that we've been working in around this new paradigm called CHAMPS. And CHAMPS stands for Children and Mothers Partnerships, in which we will work with the local community, catchment area of about 100,000, to say CMMB can provide some maternal and child health counsel to you and to help strengthen the existing health systems in the country. And so working with the local community first, we'll go in and do the assessment and then work with the community to do the design to really help build an infrastructure that will address the health needs. And one of the key things we're finding, as we're all talking about specifically at this conference, is how extreme poverty is really at the root of these health issues. And so as I go through some of these slides, you'll be able to see, I'm not going to read them out, they'll be available on the web and the like, but you'll see some of the key findings that we're having related to poverty, and it's linked to maternal and child health issues. And we're really digging deep into the analysis that comes out of WHO, that comes out of Ministry of Health data to say, if we can help with maternal and child health issues, we can really strengthen the community, because women and children are core to that growth in the health market. And we're seeing here in Haiti, in Kenya, South Sudan, Zambia, some of the stats that are driving those interventions. One of the other things we're adding to our portfolio is, rather than just being medicine and programmatic interventions, we're also looking at nutrition, sanitation, water and sanitation, to be key to a long-term comprehensive approach to what we're doing. So we've been very focused on the short term, I think, as global health professionals, and now we need to think a little bit more about the longer term interventions. So we're looking at an integrated approach, not just coming in with one specific program, but working in a collective impact framework to work with local partners, to work with the community, to bring a holistic approach to what we're doing. So CHAMPS is a 15-year commitment by CMMB to convene local partners to really move the needle on impact in global health, specifically around maternal and child health, which is our focus, and bring people together to provide nutrition and economic empowerment to help with the poverty issues, and then strengthening health systems, which we think can be one of our core competencies. And our goal is to have about 20 of these CHAMPS initiated worldwide by 2020. So we have several examples of our early work to share. and hopefully we have a nice dialogue about that. But I want to keep moving because we have some great presentations today. But our first has been in Côte d'Ivoire, Haiti. Côte d'Ivoire is on the southern coast of Haiti. We have offices in Jacmel. The Ministry of Health and the Bishops' Conference said to us after the earthquake, this is a very neglected area that's not raising up to anybody's awareness after the tragedies in Port-au-Prince, and we really need your help, CMMB. Would you help us by creating a health facility that will be core to the community and that will then be a primary health spot that can be referred to the hospitals in Jacmel in the area? So we are not known for building. We're not bricks and mortar people. We're health system strengthening folks. But we agreed because when we did the assessment, we found that the infrastructure there was just not enough to be able to be helpful. So we went in and we did the assessment and we engaged the community at the very basic level to say, what are the needs? What can we do to convene partners? And how can we move forward? And then we did a design with the community, with the leaders, with the local indigenous religious communities, in cooperation with the Ministry of Health, and came out with some activities that we know are going to be really important to the long-term viability. And one of those was nutrition and economic empowerment, to really help to address the needs of poverty as it relates, which is a very, very poor community in Côte d'Ivoire. So these are some of the activities that we've designed around nutrition and economic empowerment, and hopefully provide some insight into what we're trying to do globally. So each of the communities, we brought goats and gardens to help the mothers in particular create some economic enterprise. And we gift 2 goats to each family, and in concert also have a home garden so that some of those goats could then be sold to provide additional income for the family. Some of the vegetables and other produce that were created could also be brought to market, and those have been very helpful to the community. We've also introduced moringa trees so that those leaves can be helpful to the overall nutrition of the family, and we're seeing some good results already from our early work in that. And now we're trying to broaden this into all the CHAMP sites that we're doing, and I'll show you some examples in a few moments. We've always been known as an organization that provides health system strengthening, and that's a key buzzword in what's happening, obviously, in the last couple of years. But what does that mean from the CMMB perspective? That means to really strengthen the clinic where we're working, provide that maternal and child health professional expertise from the doctors who run our programs to the medical volunteers that we bring in to build capacity, and to the community health workers that we work so closely with around the world. So you hear some of the framework in which you can see what health system strengthening means to us. The community health workers is key because we do a lot of community engagement around education, good healthy habits, about making sure people know where the health infrastructure is, and then trying to provide transportation and support to get people to those key resources. A couple of places where we have some good work working is in Wandi, Zambia. We're identifying the challenges there. There's lots of good partners. Frank and the Presbyterian Mission Group have been there for many, many years, so we have great partners that we can work with, but we have basic infrastructure issues. All of these relate to the problem with poverty at the community level. So we're trying to get our champs to provide some of the solutions. We're building up the capacity for the local folks to have the ability to service the healthcare. We're bringing in some tools, diagnostics, to make that possible. We continue to bring our medicine and our medical volunteers and integrate that. And we're working to really provide a lot of education and stakeholder empowerment. In Huancayo, Peru, we work with the local religious sisters. The Bon Secours Sisters worldwide have a strong indigenous community there that we work with. So we're identifying what are some of the major healthcare issues are there, And obviously, as we're finding, the need for economic empowerment resides in the community. So we're providing that as a platform as well. And one of the key things we're doing there is in Huancayo is providing guinea pigs. While we're using goats and gardens in Haiti, that context would not work in Peru. So the community tells us, we really don't need goats and gardens. What else could we do to support a similar outcome? So we're using guinea pigs as a way of bringing nutrition and economic empowerment to our community in Huancayo. And we're now modeling that across 3 other sites in Peru. Cote d'Ivoire, we talked a little bit about. We are building a facility there, healthcare facility, about 30-bed facility. It's going to be named in honor of one of our former board members, Bishop Joe Sullivan. And that'll open probably in the summer next year. Motomo, Kenya, here are the challenges that we've identified. Working with traditional birth attendants, making sure we can get pregnant women to the facilities, building up the infrastructure of the facilities to take care of maternal and child health issues, and supporting the diagnostics and community health workers in Kenya. South Sudan is a huge, huge new platform for us. 3 CHAMP sites under development. Nazara is one where we've brought water and sanitation to the forefront because that kind of empowerment is going to help address a lot of the healthcare challenges there. And working with the Ministry of Health, U.S.A. and a lot of the other partners who have identified this as a healthcare emergency in bringing some of those solutions to bear. So a call to action. We want to partner with all of you who have the ability to bring some of those expertise to the table. And we would like to convene a platform and a common agenda of all the folks from the local level to the international partners to really help challenge and solve some of these issues. Thank you.
Thank you, Adrian. Our next speaker is Mirfin Mpundi. He will introduce himself. Thank you.
Good afternoon. It's certainly good to be back this year at this conference, but also to be back in my neighborhood. A few years ago, I did my trade right here in Maryland and also in Virginia. I'm a pharmacist by profession, and I work for this organization, EPN, as the executive director of EPN. Looking at poverty and what EPN is trying to do, I'll simply give you 3 examples of what we are doing. This is the problem that we often see in most sub-Saharan Africa and in most of the African countries. You go to a pharmacy, after the interaction between a physician or a clinical practitioner, a nurse, the clinical officer, really what results is a prescription, and they walk to the pharmacy and they find that. So that would say something about the poverty levels and whether we're trying to solve that or not. That is also a problem because that's too excessive. Again, you've got, that's a slide that shows you can move to the other extreme, excess and not access. This other slide was taken just last week in DRC. We've got some work we're doing in DRC, and this particular facility in DRC, they enable a richer facility. So the richer facility, once they are reaching 3-4 months of expiry of medication, they donate to these guys. And these guys can't even sort them out in those boxes. So that's what is on the ground. What is EPN? We are an ecumenical network that values to be a global partner for just and compassionate quality pharmaceutical services for all. Our buzzword really is that we believe that each and every human being should have a right and has a right to access quality assured medicines when they need them. But that's not typically what happens, and we've been in existence for actually 30 years, plus actually 34 years this year. Our strategic goals and plans, we are transitioning from the 2010 to 2015, where we focused on access to quality assured medicines, and there we strengthen supply chain systems, procurement, really capacity building, really through actually strengthening the pharmaceutical system, and also looking at the pharmaceutical care as a holistic approach. But we also focused on HIV and AIDS. Here we focus primarily on the church leaders, building their level of understanding of HIV and supporting the patients by the reduction of stigma and promoting actually taking of ARTs. Because most of them, if you recall, would tell someone, you know, we've prayed for you, you're good enough, God bless you, you are healed, you go. They go, they don't take medication, what happens? They die. Oh, and so I mean, their families continue in such a sense of poverty. We do a lot of training in terms of capacity building, and that has been one of our core areas where we go into facilities. Most of you might know that the majority of the workers in the pharmacy sector in faith-based organizations are not pharmacy trained. So we go in and we try to build a level of capacity in these folks that are working in these areas. But we also provide scholarships to those that work in faith-based institutions so they can go and get a diploma and become a pharmacy technician or technologist. Really, currently, we've got 27 students in a number of countries: Kenya, Tanzania, Zambia, Cameroon, DRC. All those we send them particularly into pharmacy schools. And in doing so, we also allow the sense of actually looking at gender and promoting governance in institutions in trying to get us the folks that we can send for training. We also are in research and information sharing on pharmaceuticals. And the next strategic plan that we are moving into, our main focus areas are going to be NCDs, big issue, maternal and child health, antimicrobial resistance, with the three cross-cutting areas: advocacy, capacity building, and research and information sharing. Those will support the latter three. We are a network of 89 members and spread across 35 countries in the world. Our members are church health associations, drug supply organizations, and individual members that identify with the mission and goals of EPN. What are the access problems that we normally face? Stockouts, the cost, non-availability of medicines on the local market. Most of the government central stores in most of the countries in Africa, their primary customer and focus are their own institutions. So you go in as an FBO, they'll tell you, hold a minute, first we serve our folks and then we'll come to you. And so that creates a major problem. Largely, most of our countries and the FBOs that we work with have got very weak supply chains. We have a few examples that are very strong. An example is meds. I mean, Samuel this morning had shown you that great picture of meds. That's one of our members who've got a very strong pharmaceutical supply chain system, but by and large, most of them are going to be weak. We've got capacity gaps. We did a study with WHO refocusing on the capacity of the folks that we have in terms of human resource, and it's quite scary when you go to most of these countries. Unregulated illegal market, that's one of them. Examples of partnership that we're working on. We are working on food procurement as a means of promoting access, availability, and affordability of drugs in the member countries that we work in. If you go in, this slide portrays, I mean, if you go in alone and buy, you can buy a very small quantity of medicines, but pay tons of dollars. If you buy more, of course, they'll give you some break, but still you're going to pay more. The last one shows you if you buy as a group, you make a lot of savings. In Cameroon, we're working with three groups, the Baptists, the Evangelicals, and the Presbyterians. And what we have done there is that we've had savings close to 40%. So that means that the savings that they are making, they can use them in strengthening the other areas of their health systems. We've got, there's a food procurement that we're doing in Kenya, and that brings together 4 drug supply organizations, one in Rwanda, one in Uganda. Tony's group, Tony presented in the morning, one in one in Rwanda. And there again, we have been able, at least we think we'll save close to $500,000. And so that again, they can take and invest in the other areas of the health systems. Yes, we have challenges because we're working across countries and also bringing 4 different groups, different capacities. Some are very weak, some are strong, some are medium. But those are challenges that we work with. And these are some of them. Really, I won't go through each one of them. Trust and management buy-in is one of the greatest ones, because you really to go and convince the CEO to say, let's partner with MEMS in Tanzania, let's partner with joint medical stores and put money together, that becomes an issue. But there are also issues of, issues where you have to reconcile the prescribers' desires and what they are used. One will tell you, I only use this beta blocker, I'm not going to use the other. So we have to involve them in this process. At the end of the day, if we do that, we do well. We also work on quality of medicines. That's a mini lab. What it does, it gives you a preliminary screening whether the quality of that particular medication meets the standards or not. And we have done quite a lot. Damning statistics, really. 30% of drugs on the market across the globe now are counterfeit medicines. You're talking of 100,000 deaths in Africa a year because of just counterfeit medicines. And we have set up Sentinel sites in 9 countries where we screen these drugs and we send them over to WHO. We've got a number of drugs that have failed. Anti-malarials, Ricoatem, antibiotics. All these I'm showing here, they have failed. I can give you more details later. And these, again, what these companies have done, they go for the low cost but high volume drugs. And there are just too many counterfeits on the market. One recent project that we are doing with CCIH is that we're trying to look at ways of promoting FP commodities, and that's sponsored by actually Bill and Melinda Gates Foundation. And the main problems we have are stockouts of commodities, information and knowledge gaps, and to have a buy-in of some of the religious leaders for these commodities is an issue. This is, again, another way that we think that we can be able to at least reduce and mitigate the poverty levels. We just finished a survey and analyzed our results last week for actually Cameroon, DRC, Ethiopia, and Nigeria. My colleagues are working on Kenya and Zambia. And we will develop an advocacy plan to try and promote these commodities access. What are the outcomes of our assessment? Commodities are not easy to get. Misinformation and knowledge gaps, family factors. I cannot go on this pill unless my husband approves it. Opposition from church leaders. We had an interesting story of one of the Catholic nuns who said to us, my church or my leaders at this particular congregation, they won't allow me, but what do? We give them without them knowing. Partnership, what are we talking about? It's not easy. You've got to keep pushing, and there are a lot of roadblocks that come in. You've gone far, and then one leader says, my organization does not have money to do that. You've made commitments, you've gone through the tenders, what do you do? FBOs can't purchase any cheaper medicines, but it's worth it. DSOs can afford. They can make savings, like I said. In the process, we build capacity and resource sharing. I know these are benefits that we are getting out of the partnerships. In conclusion, strong partnerships, I believe, for FBOs in Africa will lead to really increasing access, and that's what we're trying to achieve. Increased accessibility. You can have access, but you cannot afford it. So through mechanisms of put procurement, we can lower the prices, lower the cost of medicine so that other folks, those that are living really below the poverty debt line, can afford that. Partnerships for us, my experience in all this, are not easy, but they are worth supporting. And you can join us in supporting this. For us, really frankly, it's all about the patient. And it's all about access, access, access. If you can have that, you can see we started with a slide with nothing. Almost. Another slide with excess. Another slide full of expired medication. If we can have This picture where really patients can come in. The reason that you and I go to see a physician, at the end of the day, we don't care about the scans. We don't care about the labs. You know, I've got pain, give me a pill and I'll go home. So it's all about access, 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 access. Thank you.
Thank you so much, Mirfin. We're going to hear from our last speaker, Frank, and then we'll have a wonderful discussion. Thank you.
Good afternoon. Let's try that again. Good afternoon. Thank you. My name's Frank Dimmock. I'm with the Presbyterian Church U.S.A. World Mission Program. The PCUSA has been involved in world mission globally for 178 years and is engaged in more than 50 countries with nearly 200 partners around the world. Although I come from a public health background and 30 years in Africa and health, I'm now at least initially focused on quality education and addressing the underlying causes of poverty. Poverty and education and health are really inseparable when you address poverty. And my presentation today will look at education and where the Christian community, especially the Presbyterian Church and especially in Africa, is engaged. Well, that didn't work. Oh, that did. Okay. About 2 years ago, when I was asked to take this job to address global poverty, I did an exercise, a mapping exercise. I enjoy mapping. And I tried to consider what are all the issues related to poverty? How do they interrelate, and where should we begin? Poverty is multidimensional, it's complex, it's intergenerational, and it's universal. It's everywhere. And as Amartya Sen, the recipient of the 1998 Nobel Prize in Economics, says, he defines poverty as the lack of freedom or opportunity. Or viewed from a different perspective, or underdevelopment has to do with the lack of personal freedom, including political freedom, economic empowerment, social opportunities, personal security, and integrity. So you can begin to see from this web the complex interrelationships between the various poverty drivers, factors such as conflict and displacement, disease and access to essential services, political stability, et cetera, et cetera. Well, much effort has been given to identifying the risks and vulnerabilities and even measuring them. And considerable energy and expense has gone into responding to many of these shocks or issues. And soon we'll have 17 new goals and 169 targets to work on as part of our sustainable development. But what about the underlying causes of these issues? In medicine, we know the difference between treatment and prevention. We get excited when a treatment prevents a reoccurrence. But what can we do together to most appropriately address the root causes of poverty? How can we help strengthen individual and community resilience, and where do we start? Well, the Presbyterian World Mission Program has listened to the priority needs of its global partners. We've read the reports, and together we've launched a campaign to strengthen quality education for 1 million children by the year 2020. Sustainable Development Goal number 4 that's been proposed identifies inclusive and equitable quality education as a major goal for the next 15 years. Ours is a campaign that includes public education in the United States, as well as partner education programs in some of the 50 countries that we work with. There is a global education crisis, a global learning crisis. Classrooms are crowded. There are too few classrooms or qualified teachers, especially in rural areas. There's also a large gap in the education access and outcomes that perpetuates the inequality within and between countries. Education inequality, as determined by not only enrollment but attainment, is morally unacceptable and is socially dangerous. Paul referred to this knowledge gap last night, and in a recent Brookings report, it states it will take another 65 years before developing regions of the world reach the levels of education seen in developed countries today. So there's a huge gap, and that gap is increasing. And here in the United States, school dropout rates are extremely high, a major challenge. Well, what are the facts? For the benefit of the factivists in this room, I've listed some of the facts around education as a means of transforming lives. And we know that education transforms lives. It transformed Nelson Mandela and provided him with a vision for the future of South Africa and a gateway out of poverty. He received his early education at a mission school. Education is also a good investment. The dividends that result from investments in education are immeasurable. Some experts estimate that they're tenfold. For every dollar that's invested in education, there's a $10 return. Sometimes this is referred to as the education growth premium. So what are the objectives of our education campaign, and how is the church going to help address the gaps? Education is crucial to peace building and for fostering more cohesive societies. Education also helps to address the inequalities that generate conflict. So our first project has involved teacher training and resourcing in South Sudan. Education as a priority in global development assistance has been declining in recent years, with few exceptions, and is always less than that given to health. Numerous studies have shown that the period from birth to 6 years of age is extremely important in cognitive and social development and in school completion. We also know how critically important it is for young children to be attached to a caring adult during that period. There's also evidence showing how poverty can create conditions of toxic stress and weaken brain development during early childhood and beyond. Often poverty is correlated with adverse childhood experiences, resulting in negative health consequences for adolescence and into adulthood. So helping to develop and strengthen early childhood education and development is a priority objective. For example, we know that there are more than 3,000 Presbyterian congregations in the U.S. that host a preschool program. It's important to increase and improve these programs and encourage sister denominations and faith groups to do likewise. Quality education depends on quality teaching. Teachers who are professionally trained and resourced to encourage learning. We want no teacher left behind. Such programs are taking place in South Sudan and in Bangladesh and in Guatemala. And here in the U.S., there are teacher mentors providing help to new teachers with support from U.S. congregations. A challenge that some of our partners globally have expressed is the difficulty of placing qualified teachers in rural areas that have few resources and in providing ongoing professional development opportunities. Sounds like health workers. So we're examining the appropriate incentives for teachers in rural areas. The futures of these kids will be brighter if they can stay in school. They're less likely to engage in risky behavior or dangerous work or get married at an early age if they can remain in school. I also want to give a shout out to the Menstrual Hygiene Management Program and the Productive School Sanitation Programs that were referred to by Linda in her presentation last night. We're providing such programs to enable adolescent girls to continue their schooling in Malawi and in Zambia and expanding those elsewhere. Many partner churches are reaching out to the least of these, the most vulnerable of the children. For example, in Malawi, there are 8 schools for children with special needs, including secondary schools that are offered by the church. These are among the more than 1,000 schools that are managed by Presbyterian churches in Malawi alone. Providing education for children in camps is equally challenging to that of providing health services. we're assisting the Synod of Syria and Lebanon to extend services in Lebanon to Syrian refugee children. 1 week ago today was World Refugee Day. I don't know how many of you celebrated, but the fact is there are more than 30 million children around the world who are displaced from their homes and schools by conflict and emergencies. That's more than half the total refugee population, and they need an opportunity to learn. Every day last year, on average, 42,500 people became refugees. Each day, asylum seekers or internally displaced. At this school in Thailand, near the border with Burma, children have few opportunities to learn beyond grade 6 due to certain language barriers. We heard about that a bit last night as well. Their future options would be limited unless the church came alongside to expand their education opportunities. These are some of the resources around education that I've referred to in my presentation. Why Wait 100 Years is the Brookings report that came out recently about the growing gap between developed and developing countries in education. Some other reports that were referenced on health. But thank you anyway for your attention.
Thank you so much for our presenters. We went from maternal and child health to treating and access to treatment or medicines to treat illnesses, to education, which definitely empowers and improves health outcomes for communities, and we all know that in the literature. So I'm going to start out with 3 questions, one to each of our presenters, and then I'll let you ask them questions. And my first question is to you, Mr. here, very close to me. In your presentation, I saw a slide that talked about maternal and child health, and I think that's your projected sort of area of focus for strategic development. And we know that gender is a cross-cutting theme in our development and health concerns. So I'm just curious to know, how are you factoring women into procurement of medications or whatever it is that you do to improve health outcomes, but really having women play a role in the work that you do?
Yeah, thank you very much. I think one of the things that we should be able to mention, I think from the outset, is that the goals really for poverty reduction and the goals that we have in terms of gender equality, it's important that actually they work in a synergistic way, because it's not that if you actually increase or promote equality of gender, then automatically you're reducing poverty. That's not the way it is. The way that we look at it really for us is that it is important to provide quality assured medicines to mothers, to children, and to fathers, because if you do not, you prolong at the time of treatment. It's very costly because you're going to buy more medicines and not getting well. Maybe death occurs. So we try to factor in that, there has to be medications focusing primarily on women and on children. And you cannot treat the children as little adults. And we've done studies and interventions that have looked at countries where really children medicine and women medicines were not a priority. So we focused on that. When we do the capacity building, I mentioned scholarships as one example, and also the trainings that we offer on supply chain. We make it clearly that we will support more women in those programs, and we involve the governance structure of an organization, because it's one thing to send a woman to school, they come back, but they won't recognize them, they won't give them a pay raise, they will not look at it. So we involve the governance structure of the organization so that they look at it in a holistic way and promote that gender gap.
Thank you so much. And my next question is to Adrian, and I'm going to read it because it's a very, very beautiful quote that I found. And it says that success is increased when detailed attention is paid to the local context and involvement of local community in poverty reduction. So I guess my question is, and you did talk about it, but I'd just like you to focus on it a little bit more, is how has your work, or how has local community involvement worked or not worked well in your programs, and how has it made a difference, if any?
Yes. Thank you. It's actually essential to what we're doing with this collective impact framework that we're working on. I think there's a lot of discussion about collective impact and its effectiveness and efficiency, but the key piece of that is really the local context. Beginning the work with the community, doing the assessment and design in cooperation and if not led by the community, and finding those key deliverables and the framework for measurement, creating the common agenda so that we're not only saying these are the data that's going to help CMMB showcase what we're doing, but it's actually going to go back to the community to say, here's how we're tracking and these are ways for improvement. So it's essential. It's essential to what we're doing. We're finding that in doing these baseline assessments and designs, the community comes in a much richer position. They really have the buy-in and the willingness to work with the partners if they're at the table from the very beginning. So we try to take a much fallback position to be a facilitator or convener of the partners, but the community leads. And that's where we come up with some of the results related to nutrition, economic empowerment of things we may not have seen early on. Say, if you want to create these opportunities to give us greater health opportunities, we're going to need to be able to get there. Transportation, how can we pay for transportation? Then we talked about economic empowerment, so there'll be more resources for the family to travel, than to afford any of the primary health care pieces, to access the medicine. So those are some of the examples that have come out.
Thank you so much. And the reason I ask, and I thank you for your answer, is because typically in measuring poverty reduction, we tend to focus on individuals that we have been able to help, other than communities that we have been able to help out of poverty as communities. Therefore, the local context becomes very, very important in planning and implementing poverty reduction programs. And then my last question, before I let you guys ask questions too, goes to Frank. You talked about... Oh, good. Yeah, you talked about the benefits of personal freedom and opportunity that that people need to feel, that the sense of control about their lives and how they reduce poverty. Could you say a little bit more about how that works in your programs, especially for people that have been trapped in poverty for a long time and are in a culture of poverty? How does your program help, partnerships help that?
Do our 15 minutes start over? Thank you. A lot of our work is with children, and children who are living in poverty are focused on survival. In fact, so many folks that we work with, children and adults, are focused on the today, on survival. Their view of the world is limited by the streets or the slums or the landfills that they live and work in. Our effort is to go to them with health and education, wherever possible, in Smoky Mountain and Manila and other places where we can reach out to those who have a very limited or bounded view of the world because of their situation, because of poverty. So we are working alongside national churches, partners that are part of the community and are invested in that community and trying to strengthen their capacity to reach out to the least of these.
Want to ask questions? Anybody has a question? Maybe 2 or 3 questions?
Hi, my name is Mekam Ikon, and I'm with the advisory board company. My question is for you, Adrian. You said you partnered with the Ministry of Health in Haiti, and how often do you have those partnerships with the government, and what obstacles do you face, especially with competing agendas?
I think it's essential to partner with the Ministry of Health in the country where you work? So building off those relationships that we have related to the HIV/AIDS epidemic, and then the networks we built there, those have been trusted relationships. So they'll look to CMMB and say, you know, can you help us in this sector? Can you follow some of the guidelines we've put together? So it's essential when we come into a community that we're tying into the Ministry of Health's plan for that area. So if you don't do that, that creates a lot of tension, and the relationship there is essential. So while we're trying to make sure that the community creates their own agenda, it has to nest into the overall agenda for the Ministry of Health. So I would say that those relationships are good. There's lots of dialogue, as I'm sure all of you know who work in that context, that the dialogue has to be back and forth, because we're going to bring some things to the table, say, you may be missing this, and we want to try and help.
My name is Elliot Larson from Christian Journal Public Health. My question is for Frank Dimmock. One of the things I've heard about in Africa has been the development of local private schools. These are sometimes resisted and opposed by the government education, and also by the elite private schools. Is there a way in which the mission can support these opportunities? Because it seems to me they fulfill your criteria of freedom, and their results have also been superior to the government schools.
If these private schools are offering access to the most marginalized children, the most vulnerable children, to a quality education, yes, we'll work with them. We'll try and support them and work alongside. There are over 6,000 schools that are provided by our church partners throughout Africa, and so we have a lot to do to try and strengthen the quality there. But as you say, there are many of these small private schools, mostly around urban areas, that have started up that are perhaps not regulated or accredited with the Ministry of Education. So there are some challenges there to partnering. But I think in the rural areas where a lot of our work is focused, we're willing to work with anyone who's really providing quality education for children who don't have access otherwise.
Thank you for your presentation. Looking at the maternal child health project you talk about, I'm just interested to know, in your work with the community and with the target group that you work with, looking at reducing maternal child health, what could be some of the strength of the target group that you might have experienced or identified that you will build on to help them prevent maternal death in their communities? What could be some of those strengths that you might have identified?
Well, quickly, I think I'll say two things. One is knowledge and information. Once you empower them with that, that goes a long way. But secondly, we also work with church leaders so that they can be the basis of that support and provide, because really, sorry to say this, but the church leaders, whether we like it or not, they hold so much power. What they say, it's like really, it's Archangel Michael saying something, because they are very close to God. So, you have to get their buy-in in something. And once they do, they become your champions and they support your efforts. Without that, frankly speaking, it's hard.
Thank you so much. Are we out of time completely? Or? I would like to thank you so much for your time. I'm going to teach you a way to clap in Uganda. When you clap for yourself, which I want you to do for being patient and bearing with the rain. I don't know what's worse, the air conditioning or the rain. So when you're clapping for yourself, you clap this way. So clap for yourselves. Very nice. And then to our presenters for this. Thank you.